brief about the anatomy of axillary lymph nodes. What are the level of lymph nodes which we deal while we are doing breast cancer?
As per level three levels are there: level 1, level 2, level 3, based on the anatomical disposition of pectoralis minor muscle. Beneath the minor muscle is level 2, below the inferior collar of pectoralis minor it is level 1, and above the superior collar of pectoralis minor it is level 3. A lotus group is interpectoral group of lymph nodes between pectoralis major and pectoralis minor. Then there is supracervical lymph nodes and internal mammary lymph nodes.
Okay, so after anatomy, it's just about the brief anatomy. When we start thinking about managing this breast cancer patients, so managing axilla is a real tough job. What to do, what not to do. So our first concern is what is the diagnostic radiological technique which we perform on the patients. So, Dr. Saurabh, what do you think on suspicion of axillary lymph node on clinical examination? What imaging modality will you prescribe to your patients? Dr. Sakrishi. What are the imaging modalities? So, according to you, mammography and ultrasound
of bilateral breast.
So, what do you think on mammography? What you want to see in mammography regarding axillary lymphadenopathy? So, what are the findings which you see on mammography?
So basically, the main primary lesion is means visible in mammography, and we give a BIDATS coding for that.
Yeah.
So according to the BIDATS code, then we proceed to the true cut biopsy and ERPR HER2 new status.
Okay. So, Dr. Suhadeep, what are the findings you think of while you discuss with your radiologist regarding mammographic findings of axillary lymph node? What are the typical findings of axillary lymphadenopathy in mammography?
Yeah, see, generally shows a hilar obliteration is one of the findings that we can see. We look for pleomorphic calcifications, and which have to look whether there are indistinct margins or there are fatty infiltrations in the nodes. So that is one of the things that are done. But in practice, generally, patients generally come with their investigation done. So when these are not mentioned, we use a plain simple USG to evaluate.
Yeah, so on mammography we have multiple findings like pleomorphic microcalcifications, then indistinct margins, fatty infiltration, hilar obliterations. Dr. Santosh, on ultrasound, USG Doppler, as said by Dr. Ghosh, what you see, what you want your radiologist to comment on with USG Doppler regarding axillary findings?
The radiologist to comment regarding the total architecture of the axillary nodes and its hilar existence, including its fatty calcified status of the axillary nodes and some other, if there is any calcification or significant matting of the nodes or the voluminous status of the axillary nodes.
So our panel is very sure that these are the two investigations, mammography and ultrasound with Doppler. They are the main diagnostic tool for imaging axilla in case of carcinoma breast. Dr. Menak, anything apart from mammography and ultrasound Doppler? And what do you think?
Mammography, high resolution ultrasound and mammography are the most commonly used techniques routinely performed. However, some studies are showing that when mammographically or by ultrasound, level 3 nodes cannot be seen or Rotter's nodes can be missed, which can be seen by cross-sectional imaging. But this has not been category level 1 in NCCN, it's still in 2B level. So till now it is high resolution ultrasound with Doppler as well as mammography are the most preferable to diagnose the axillary nodal stones.
Okay, Sagnik,
Just I want to say is that in clinical practice, what we practice in day-to-day practice is breast is one of the area where we clinically determine whether it's a N1 node or N2 node this thing. So it's not that depend upon the mammography or other ultrasound always. We can detect if there is obvious lesion. Clinical examination is one of the as well as same modality as far as other investigation concerned. So clinical investigation in breast axilla is very important for that.
on clinical examination, that is the main area which we have to focus. Dr. Chanchal, anything about CT scan? Sorry, regarding CT scan.
Yes.
Do you routinely perform or it's very selective? You are very selective regarding CT in case of CA breast while imagining.
So we do not do a CT just to assess axillary nodes, but if we have axillary nodes, then we need to do a systemic workup. And although 15 years ago we were still satisfied with the chest X-ray and ultrasound, but today we need sectional imaging. So a CT scan at least, a thorax abdominal, and if possible a PET CT scan. I think most of us would be doing a PET CT scan if it is available.
Right. So PET CT. Dr. Ketul, when will you advise PET CT for your patients?
We generally advise PET CT in a locally advanced setting. For nodal stage, if N2 or N3 nodes are there, then we'll advise PET CT for systemic staging.
For systemic staging. So these are all regarding imaging axilla in case of CA breast. So the panel has clearly the opinion that clinical examination is the mainstay. Apart from clinical examination, high resolution mammo plus ultrasound with Doppler is the mainstay for this imaging axilla in case of CA breast. Now coming down to the management part, apart from the diagnosis, Dr. Ghosh or Dr. Menon.
Yeah.
So, what do you think in case of when you are advising neoadjuvant chemotherapy for the patient? So, if you want to have a response evaluation, what are the imaging modalities will you prescribe to your patients?
Sentinel lymph node biopsy post neoadjuvant chemotherapy, as per ACOSOG 1071, it is said that if we can go for therapeutic axillary dissection, then the false negative ratio is less. Otherwise, post neoadjuvant, the false negative rate for sentinel lymph node biopsy is higher. So the newer concept of clipping the positive nodes followed by neoadjuvant therapy, and then just before surgery, if you can tag it with radioiodine seeds, that helps. This is called the MARI procedure in recent, and the latest study that is going on is the TADEN study, which is targeted axillary dissection in early node positive breast cancer. And this is an ongoing study where this the concept of MARI is being used up, and that has helped us to identify those targeted nodes, and the false negative breast post neoadjuvant can be much reduced.
Dr. Ghosh, you have any other options while evaluating the axilla in post neoadjuvant chemotherapy patients?
So we would do CT thorax and whole abdomen to see the response, whether any METs have arrived or not, and also about the axilla, we would do a CT scan or PET CT accordingly. So,
Okay. So PET versus CT. So we are of the opinion that in response evaluation, these are options for us to look for the response evaluation. Now coming down to the surgical aspect of axilla. So, Dr. Kumar, what is the treatment of axilla in DCIs? Because it is one of the concern for majority of the general surgeons. So, surgical oncologists are very clear about it. So, how you deal in your clinical practice? How you deal with axilla in case of DCIs?
In recent practice, it has been proved that the standard mode of treatment, that is axillary node dissection, we used to do, but nowadays we have changed our theme to shift to sentinel lymph node biopsy. We will properly evaluate clinically and with other diagnostic tools. And finally, before going for surgical interventions, we'll in locally advanced cases we'll prefer for neoadjuvant chemotherapy. Then again we'll assess both clinically and with other diagnostic tools, and the sentinel lymph nodes biopsy and its evaluation and establishment is the standard choice of treatment.
Dr. Menon, do you have what are your clinical?
Sir, are we discussing of DCIS only for this?
Yeah, DCIS management of axilla.
For DCIS,
And how you manage and what are the concepts behind managing the axilla in DCIS?
in pure DCIS, the chance of axillary spread is very negligible. So we need to see by biopsy whether it's a pure DCIS or it has some invasive component or high risk components. If there are no high risk components, then we can skip the axillary part, and in PCS we are already giving the radiation. We can also go for partial breast radiation. But if there are some high risk features or there are some invasive parts are there, or we are going for total mastectomy, or we are resecting out the tumor in such a region where the future sentinel node biopsy is difficult, like in upper outer quadrant. In those regions, we should do sentinel node biopsy, even in DCIs.
Dr. Ghosh, what about radiation in managing axilla in DCIS?
So axillary radiation is not indicated. So in DCIS, we will generally opt for WLE followed by adjuvant RT.
Adjuvant.
Yeah.
So any like landmark trial to support adjuvant RT in managing axilla in DCIS?
That I don't remember.
Okay. So these are NSABP B17 and 24. They have suggested that the invasive ipsilateral breast recurrence post tamoxifen and radiation therapy, the chances of getting invasive component is very less, and hence the long-term prognosis remain excellent after these two modalities while managing axilla and DCIS. Sir, what is the importance of axillary dissection in these patients?
See, axillary dissection, previously it was the mainstay of disease management, but over the last 2 decades, it is seen the axillary dissection can be avoided. It is only a staging procedure and has got some prognostic information. Local regional control can be similarly achieved with chemotherapy and radiation therapy. In a selected subgroup of patients only, we go for axillary dissection.
So this is what we have for the management of axilla. In N0 axilla, the percentage of sentinel lymph node positivity is around, the sentinel node can be identified in 97% of the women, and at least 3 nodes has to be dissected. So the false negative sentinel lymph node biopsy of a institution based, majority of the studies have indicated that it is less than 5%, and after neoadjuvant chemotherapy the false negative rate increases. So Dr. Sagnik, what do you think, why sentinel lymph node biopsy has superseded axillary dissection in cases of managing the axilla?
So
In axilla.
we all know that it causes the lymphedema and lymphedema. And result of lymphedema, we know that the Almanac study, they showed that almost 13% of significant lymphedema. In our center, At Varanasi, we are seeing at least is more than the what Almanac shows. At least our data as per the last almost 500 cases, we have seen at least 21% as dissection. If you do the all three nodes levels, this is our data. So these are the main problem with that accelerated dissection. So that SLNB has came up in this case. So the main problem is that lymphedema of arm. That's very debilitating. That is our concern. So we are going from axillary dissection to the sentinel.
Dr. Santosh, do you have any other views regarding it? You are also presuming that it has superseded axillary lymph nodes. Okay, so these are the studies which have supported in N0, the sentinel lymph node biopsy have superseded axillary lymph node dissection, ALND, as such the procedure is. So, Dr. Subodhi, any idea regarding the targeted axillary dissection in node positive? As we have covered about the node negative, so coming down to node positive, any concern for targeted axillary dissection over ALND, proper ALND, axillary lymph node dissection?
In practice, we are not, daily practice, we are not doing that. Studies have shown that the index can be clicked or a tattoo after your NST. But again, it's still an evolving concept that we are still not doing it in regular practice.
Dr. Ketul.
At GCRI, we are practicing the sentinel lymph node biopsy post NSCT. If pre-NSCT locally advanced or early breast cancer with N0 or N1 lymph node, but we are not doing targeted axillary dissection. We are following a dual method for sentinel lymph node biopsy, and minimum 3 lymph nodes should be harvested. Yes, targeted axillary dissection decreases the FNR, but we are not practicing yet.
Dr. Sagni?
So, not targeted, what we are practicing alternative to SLNB in our resource constraints country. What we are following, like Mumbai and our center, both are from low axillary sampling, that LAS. That what we do is that lower part of the level 1 lymph node, that is below the ICBN now, we are with a small incision, incision as small as that SLNB incision itself. We take the sample and take this tissue and send for frozen. If there is node positive, we go for a total clearance, and if there is no negative, we are using it as an alternative to SLNB, where SLNB, that other logistic issues are prevailing. So we can do this, and it's a good result we are seeing based on the 1 or 2 RCT.
So for the house, it's very important message that since we are a resource constrained country, so thinking of targeted axillary dissection at this point of time is little early to say, but definitely many centers have started doing this targeted axillary dissection. So we must after some time, I think will incorporate much about this targeted axillary dissection. Coming down to Dr. Kumar, what is the concept of when we do sectioning, when we send the sample to the pathologist, as we don't have pathologist, so I think surgical oncologist will have to take the seat. So what do you think? Frozen section, how important is frozen section in our managing the eczema?
In managing the frozen section is very important because during the procedure you can go for frozen section and evaluate the status of the lymph nodes, whether it is metastatic or there is some sort of confusion. And according to that, we can go for next decision, particularly the standard modalities of treatment. Either sentinel lymph node biopsy or we prefer the standard axillary dissection.
We have Dr. Dilip Mudni is head of the department in AIIMS Bhubaneswar. We have a surgical oncologist. So straight away, Dr. Dilip, do you routinely advise ask your pathologist to use INC for in upfront patients?
ISC is not required during those studies, whatever is done. So, if it is a micrometastasis, then we will go ahead with, tell it as N1 and go ahead with further treatment. If it is micrometastasis or ITC, we don't know. It will
So
be-
in upfront patients, IH is
IH is not required.
not indicated. So the concept is very clear. In upfront patients, no IH needed to rule out micrometastasis. Radiation oncologist. So as we are, it's a very vast topic, managing the axilla and CA breast. So we have tried to take all concepts while managing it. So what do you think the management of clinical node negative axilla post lumpectomy without SLNB, ALNB? What is your plan? So the concept is that the axilla post lumpectomy, the patient has come to you post lumpectomy, no axilla has been, the axilla has not been addressed, not SLNB, not ALNB, and the patient has come to you. So, and on all clinical examination, imaging modality, the axilla is negative. So what will be your plan?
So
Post lumpectomy.
I would send the patient for SLNB. SLNB.
SLNB. So you will send the patient for SLNB straight up, Dr. Dilip.
So I have to see what is the lump size, what is the breast size. So if the upper outer quadrant is almost excised, so I may not be able to get a settlement node. In those cases, I will be doing a ALND. However, in a smaller tumor in any other quadrant, excision in other quadrants, so it is not contraindicated. We can do SLNB.
Okay. And Dr. Ghosh, what about if the SLNB is positive? Now the concept is, earlier my question was, if it is negative, then what will you do? Now the SLNB has come out to be positive. So how will you manage?
How many nodes are positive?
Okay. So just it's 3 nodes are positive.
So if 3 nodes are positive, then I will suggest for axillary clearance for those kind of patients. So for 1 to 2 nodes positive, then we can, depending on various other factors like ER positive, HER2 negative, very low tumor size, less than 3 centimeter, grade 1 and 2, postmenopausal women of more than 65 years of age. So basically the ACOSOC Z11 criteria. So according to that, we can wait and watch. If it's 3 nodes, then I think ALNG will be better.
Okay.
As sir said, in BCS, SLNB has more than or equal to 3 nodes positive, we do axillary clearance. If 1 or 2 nodes are positive, then we can send for RT as per G11.
So with 1 to 2 nodes positive, Dr. Ghosh, what will you prefer?
If all the things are there, if all the criteria are met, then I would send for ALND. I am not very much keen on axillary RT because according to the AMORAS data, that is quite biased because 90% of patients were T1, T2 basically. So we don't have any data on the T3, T4 lesions, so that can't be allocated straight away.
Okay. So any other views, Dr. Sagnik?
Yeah, can I just make a point?
Yeah.
So, I mean, mostly when we're looking at radiotherapy as an alternative for surgery, it's not usually just axillary, but it's quite often regional nodal irradiation, which actually means supraclav and the IMC as well. Now, we are quite wary of using that, especially as it includes the IML. So, I mean, it's a selective approach if you only think of axillary radiotherapy. Of course, the lymphedema rate will be lower, but I mean, I think the standard would still be to send for dissection.
Okay, and what about PMRT? Again, the question to radiation oncologist. More than or equal to 4 nodes involved.
So I think most of us in the audience will also agree that we don't look at only 4 or more, but we look at any node being positive based on the Danish studies. And also we use the Cambridge post-mastectomy score, which is based on various factors like the grade, the LBE and the tumor size. So if you have a reasonable sized tumor more than 2 centimeters with a grade 3, and you quite often have enough reason to consider radiotherapy in that situation.
So, Dr. Mena, after performing the surgery, so when will you tell your residents to send the patient for radiation to the radiation oncology department? What are the indications of radiotherapy in cases of CA breast with special regards to axilla.
If we are going for BCS, then there is no doubt we have to send the patient to radiation. Whether going to a sentinel node or not, we have to go for the whole breast radiation for that reason. And but if we are going for mastectomy, then in mastectomy we only for the high risk features, like patient is having HER2 positivity or triple negative or higher grade, or in case the margin is positive, or there is high nodal axillary nodal load. These are certain high risk features that we should be following when we should be sending the patient to radiation therapy in mastectomy. Otherwise, in BCS, we are always routinely sending the patient for breast.
So, radiation to the whole breast or to the axilla?
No, not to the axilla. Once the surgery is done in the axilla, no more radiation to the axilla. If we are going for total axillary dissection, that will lead to a very high morbidity to the patient. It's for the whole breast radiation.
So, what are the indications of axillary radiation? Radiation oncologist. After doing surgery, I have my report. I am seeing the patient that the such and such surgeon has done MRI, and then what do you think the patient has come to you? So, is there any indication to perform to give axillary radiotherapy in such patients? Yeah.
So I would never consider doing that, especially because we were mostly trained at TMH, and they were always doing a level 3 nodal dissection in those situations. And subsequently, just recently I worked in the UK, and they were actually only dissecting levels 1 and 2. So there were situations where, obviously with node positivity, we would treat the supraclav, but then we would also include the high axilla in that setting. But there is obviously then a higher risk of lymphedema if we have not just supraclav but also the high axilla.
I think in UK guidelines itself that if there is extensive EC, that's probably the only indication where you can think of axillary artery. Otherwise, not.
Okay, Sadney?
So again, as a surgeon, we always try to do more surgery. So we are going to the supraclavicular fossa clearance event. So we don't have any level 1 data on that. We are doing. We don't know that what will further data will say us. But we are still trying to avoid the radiation. But if supraclavicular node is positive, radiation usually covers the supraclavicular area in their field. But this is one of the practice we are doing because we are going beyond we are pushing our boundaries basically. So maybe this is another part of the thing where even that we can avoid whether that radiation or not after doing the supraclavicular. Because we don't have any level 1 data.
Dr. Dilip, do you agree? Or do you have any other indications where axillary artery can be given post-surgery?
We don't give axillary radiation whenever you are doing a complete axillary dissection. But whenever you are doing a sentinel node biopsy, which is positive, and you are not doing axillary dissection, then that is one indication where you give radiation. There is some soft indication where radiation is being given. Other than that, routine practice, we are not giving radiation to the axilla. Other than what they have told, we are really not practicing.
Okay, if somebody has performed the surgery and is not sure that axilla has been completely sterilized post-surgery, so what is your?
Actually, there is voluminous residual mass in the axilla or in the internal groups of nodes or smaller nodes. In that case, we have already completed the new and surgery is done. So, in case of residual mass or lymph nodal egg, we must avoid
radiation. Residual tumor after surgery, post-chemo, post-surgery, residual axilla, residual tumor in the axilla. What will be your management? Post-chemo, post-surgery, residual tumor in the axilla.
So I will definitely.
So these are the things we encounter because majority of the centers, small centers, they do not surgical oncologists, they do, and then they send the patient on imaging diagnostic techniques. We see tumor in the axilla. So this is a concern whether to reoperate or to send it to you. So what is your view regarding this?
So I guess this kind of patient is means she has undergone surgery, then received chemo, and then come to us, and then we see an axillary deposit in the planning CT, right?
The patient has received full neoadjuvant chemotherapy, then surgery,
Okay.
residual tumor.
So first of all, I will do a restaging PET to determine whether there are any other mets or not, because this is a very
No
high
meds.
But if it's there, then I will again send back to the surgeon for a resurgery.
Dr. Dilip.
Residual tumor means after complete dissection there is residual tumor, or
In the axilla.
axilla it is the patient came with
Yeah.
disease
The tumor
in
is-
situ.
The disease is there.
Okay, we have to
So
do a
even
complete
after
dissection.
restaging, you have seen that the patient has residual tumor in the axilla. So how will you proceed? Whether you will go for resurgery or you will send the patient to radiation.
If it is a curative patient, after doing all the investigation whatever required, if not done, then we have to do a curative surgery.
Go for again the tumor board. Later, the tumor board it will be decided which modality should be accepted. Mostly it will be radiation.
Yeah, Dr. Mena.
Sir, after doing an axillary lymph node dissection, if there is residual tumor, that means we have to first see whether the axillary lymph node dissection was thorough or not. More than 10 nodes are there in the sample or not. If the inadequate lymph node dissection, then obviously there are some role of radiation. Otherwise, radiating after thorough axillary dissection is most morbid to the patient and is not helping in the overall and disease-free survival into the patient. And with the advent of newer therapies, we have to first stage the patient, get a PET CT done, and accordingly we have to plan. Giving a very morbid life after post-axillary dissection is not justified. It's better that we go for systemic therapy.
Even after surgery, the axilla is not stabilized. Then what will you do? Surgery or radiation?
Surgery should be tried as much as possible. If not possible, radiation is not the answer. We have to go for systemic chemotherapy.
Dr. Ketu.
I would like to add one thing. There are two possibilities. One, there may be post-operative changes. Sometimes, even in PET CT, it appears like a mass. So, whenever possible, radiological diagnosis, if possible, of recurrence should be done. And we have to see the previous operative notes, or if we are the surgeon, then whether the disease was operable or not. If it is studied with the axillary vein or the area which is not possible to operate again, then better to give radiation therapy rather than operating again.
Dr. Sagne, inoperable tumor. Axilla is studied with inoperable tumor. Now,
I think in that case, you see what's the disease biology. If triple negative, inoperable, only systemic therapy, no other radiation.
Yes.
Clear cut.
and when will you send the patient for radiation? When will you address as a radiation oncologist in this setting? Tumor studied in the axilla, inoperable tumor. The surgical oncologist has returned back to you. So what will you do?
So if it's inoperable and we do the staging scan and nothing is there else apart from the axilla, then we would go for, I believe the patient has already received EC and T beforehand. So now I would think of probably some capecitabine or something like that, and reassess after few cycles of chemo, and then again plan accordingly.
It will be same in both settings, triple negative and other.
No, that depends on the, obviously it depends on the histology. So basically the capecitabine data is coming from the triple createx trial. So we would, if it's triple negative, then we would also do the BRCA of the patient, because according to now the olaparib is into play. So and then in the Catherine data is there for HER2. So then we would just jump to TDM1 and all. So those kind of things have to be thought of. And if it's ER positive, ER positive, and postmenopausal or premenopausal, in postmenopausal we will always go for letrozole and those kind of things. And in premenopausal also we would think of ovarian ablation plus letrozole in these kind of cases.
Dr. Saini.
Just to say that if I accident dissection, there is a residual disease, the surgeon must have aware that we have done the incomplete dissection. Either that node is stuck to the vein that is not resectable. Sometimes we do the node with some part of axillary vein also.
Yeah.
So I am aware that I have done a incomplete surgery. We have not done a difference. That weak node we usually do the level 3. So that surgeon immediately after the surgery knows there is a residual disease, first of all. If surgeon feels there is adequate dissection done and then before completion of the all treatment the disease has recurred, yes, this disease biology must have been, but either it's HER2 positive or triple negative. So that time I feel if we need to confirm that with at least FNA or biopsy whether this disease is either post-operative changes or a true recurrence.
Yeah. So when we have this unique problem with us, it's better to go for some FNAC to prove that actually it is a tumor. So if it is tumor as said by Dr. Sagnik as well as Dr. Ketul, so we have to prove it, and if it is there, whether it is operable or inoperable. If operable, surgery is the best. If it is inoperable, then again we have to stage it, restage it, and then we have to consider whether to go for which side of the systemic chemotherapy.
Just a note, in such case, would you like to do a dehistology of this kind of patient?
So again, the same question comes to Dr. Sagnik. Yeah, radiation.
There is a 10% concordance or discordance after chemotherapy. So we need to, it may change that disease was HER2 positive and after chemotherapy it has changed to HER2 negative. So in this thing we need to do again the IHC and then we need to decide. Yeah, definitely we need.
So with this, we have completed our panel discussion. Thanks a lot. Thank you, my panelists. Thanks.